Hey, everybody, welcome back to the You're Not Broken podcast. So, for the longest time, we've just told people to be grateful for a cure when it comes to cancer. And more, we're realizing we're probably causing more harm than good and not helping their quality of life. And the huge elephant in the room, especially with female cancer treatment, is sexuality, completely ignored. So, I'm super excited to have on today Erin Sullivan Wagner, who I heard about through Ishwish 2025 when people started saying her talk was amazing. You need to have her on your podcast. So thank you for coming on my podcast.
Thank you. That's nice to hear. Thank you for having me.
What did Ishwish reach out to you? Were they like specifically give us a talk about
Yeah,
sexuality post cancer? Can you talk about like how that talk happened, and then your story is, I think people are very interested in that.
sure. So first of all, regarding the talk, I was approached to talk about trauma and cancer, and I didn't. I work with a lot of clinicians around the country, and so I didn't really think much about the topic until it got a little closer and thought, okay, wait a minute, I'm not a provider. Trauma and cancer. Oh my gosh, I think they want me to talk about my trauma. And that was something that was a little new to me, thinking about my story as being traumatic. And it's just putting that label on it that I hadn't done. But I was forced to write down the story because I had found out through telling the story about my own personal experience that it was quite emotional for me, and which tells me there's some trauma, that after all these years, it's still emotional to tell the story. So I definitely scripted it out and noticed places where, that was trauma. And, but really hadn't looked at it from that lens until I did that.
Yeah. Did you want to share with us the journey that kind of, now
Sure.
you're this big advocate and you run nonprofits and, but you weren't born that way.
Was not born that way. Didn't plan for it to be that way either. It My experience was anal cancer in 2008. So I was diagnosed because I had blood on the tissue with a bowel movement and didn't have a history of hemorrhoids, and I was 40, almost 49 years old, and so wasn't menopausal yet at that point. And when I was diagnosed, they weren't 100% sure that it was anal cancer right away. When they saw the tumor, they thought it had GYN characteristics to it, and that was because it was an HPV tumor. But so there was some fear around my diagnosis, some advanced cancer. I think this could be more serious than just cancer. This could be advanced. And so for about 48 hours, I had some, just terrorizing thoughts about all that I needed to prepare for. And 48 hours later, they took it all back, really, and said, you just have anal cancer. It was almost said like that.
Oh, phew.
You just have,
Oh,
yeah,
come on.
anal cancer. And it really did to me feel like almost nothing, like cancer with a small c. It is survivable cancer.
Mm-hmm.
I was stage 1.
Yeah,
It
you got it
was,
super early. The grateful
yeah,
thing is these things bleed, right? So
right,
they let you know
right.
when they're small. Yep. Okay.
Exactly. And so really that Friday afternoon, we walked out of there, my husband and I just high-fiving each other that, woohoo, cancer. And had 5 weeks of radiation and chemotherapy. And, then it got real serious in terms of it, fighting the cancer and the sick, being so sick from the radiation and dehydration and all of that. But throughout my journey, I was told that I would have no sexual health challenges. And it was interesting that I was told it because it wasn't like I asked about it. So as part of the,
Interesting. So you didn't
Mhm,
you didn't ever ask about it, and what they told you was wrong.
right. And
Yeah.
I
Okay.
was treated at an NCI designated cancer center and a, comprehensive cancer center academic. And so what I was told though is because the reason I was told that is because there are side effects listed with every treatment that you have. So chemotherapy, I had mitomycin and 5-FU. Um, and then for radiation, I had 25 rounds of radiation. So with those treatments, they list side effects that you can expect. And sexual dysfunction was listed always as a possible side effect. And it they brought it up that, we don't expect you to have sexual health challenges. And just to be really quite transparent about how difficult this was early on to have anal cancer, I didn't even know what anal cancer was. At the time that I had HPV, I didn't know I had HPV because they didn't call it HPV back in the 80s. So I didn't know anything about this. When they said I had anal cancer, I thought, oh my, wonder why I can't have a sexy cancer like breast cancer or, just something.
The one that has parades.
The one that has parades and that people know how to ask questions, second level questions about.
Yeah.
That doesn't clear a room when you say it. Just,
Yeah.
there's just a lot of quiet. And anyway, as far as the cancer type, that was a difficult just to have anal cancer. It took when I was told it was anal cancer, I remember thinking, why do I have anal cancer? And the colorectal surgeon said, we used to only see this in gay men. Now we see it in women your age. And she let that sit there. And I thought, oh, there was this time that we explored anal sex. And wow, am I going to have to talk to my mother about this? And that's what went through my mind at that appointment is, why do I have anal cancer? But it was the dots weren't connected as you have anal cancer because you have HPV. That could be cervical cancer. You happen to have anal cancer. Had we been doing anal paps, we would have found it. But I didn't know any of that. So I just connected the dots of, wow, we had anal sex once. And this is what has come back to haunt me. And I think
I don't want to say disconnect, but like many doctors know that many cancers happen for no good reason, right? The data is like a cell took a left turn instead of a right, and so then it multiplied, right? Like doctors understand, like, and that's what the data supports is most things we don't know why. It's just a genetic fluke. That's it. But that's not how brains work, right? Like brains need to find the danger so I can identify the danger so I cannot do that thing again that caused this thing, right? Like we must find it. And so you have this huge disconnect, I think, especially in cancer, but certainly for a lot of things, urinary tract infections, right? Like for lots of things of like our brains want to know why. We want a definitive beast to fight, especially in this like, cancer war against cancer, right? Find the battle. And it's pretty unsatisfying to hear like, well, we don't know now. We don't really know. It's very hard for brains to handle. So I think we probably don't do a good job understanding like how important it is to have definitive answers in a world where we don't have definitive answers.
So these are, 48 hours into a colonoscopy where we are diagnosing something early on where you are truly terrified. It's in the wake of a diagnosis, there's just pain and confusion and shock that is so hard to wrap your brain around what this new life is going to be. It's really difficult to explain to anyone who's never gone through this diagnosis period. So you really, as a patient, can feel very vulnerable. Like, I've lost my voice. I don't know how the hell I had anal cancer. I don't know how this happened. So almost a betrayal, really, of I was religious about doctor's appointments and, I was followed so closely all my life. And what did I do wrong?
Yeah. There was this movie about cancer. Seth Rogen was in it. Like, so it was humorous, but it was about a young man who had cancer, and he's in the office trying to figure out how this happened. Right? He's going through the same thing. So they portray it so beautifully, and the line that stuck out to me, he's like, "I recycle." And like it's like I'm doing everything right. And in a very humorous way of sharing that processing of like, I don't get it. and the cruelty of the universe is like, it's it's just random.
The other thing I remember, and this is maybe I should have thought about how to describe this, but there is such a vulnerability in being told that you have something that you don't believe. I don't feel like I have cancer. I don't, I'm fine. There is such a vulnerability in it that you are so afraid of what's going to come out of their mouth. So whatever they say is going to be true. It doesn't matter really what's going on with you because you can't trust what's going on with you because you feel okay. So you want them to not say anything bad. It's almost like you're
Yeah.
disconnected from, I don't need the truth. I just need you not to say it. It's
Yeah.
it's a difficult thing as a patient to feel that much vulnerability
And
about
there
what's out of control for you.
totally, and there's so much in medicine now of like labs. Like I don't feel like I have high cholesterol.
Right,
Like
right,
there's so
right,
much in
right.
medicine that it's not something we sense, but it can still be discovered and it can still be very real.
Right,
But you're like, I don't really feel like my blood glucose spikes when I have an
exactly.
orange, but
Yeah,
it's there. And so you're so dependent on this external science to tell you what, is going on in your body. It's a trip. That's not something that happens
right.
for
And when
most of
it
the
came
world.
to sexual health, that wasn't on my mind, as for, for many, and I don't know if I can say most, but for many cancer patients, that is not even on the list of concerns at the time you're given a diagnosis. It's devastating. You know you've got to battle ahead. It's the only thing.
Do you think that's more
Not
true for women? And the reason I'm asking is in my urology practice, guys are like, and I'm solving my problem as I'm asking it, but like a lot of prostate cancer, we end up not treating, right? So it's not like there's some cancers that are like Tuesday, clear your schedule. The pancreas is coming out, right? You don't have time. But for a lot of men, like testicular cancer, prostate cancer, like they bring up sex in the visit the first time. And so to me, I'm like, do you think it's a female is socialized to dismiss the sexuality, or I don't know what the right answer is, but I've had
you know
plenty of men be like, I care deeply about my ability to have an erection.
Yeah. So that is such a good question and a big topic. I do think that we as a society are behind in the female side of things in terms of we don't think about preserving sexual health. We don't honor and respect women's sexual health, like female sexual health, like we
Mhm.
do men. Because of that, we do wait and watch. We do preserve their sexual health.
Yeah.
We don't do as much. There haven't been as many studies studying female sexual health. Um, we
And
aren't
it's almost like
culturally
you have to bring it up. You have to be suffering enough. It's like the burden is on you
correct.
as the female, whereas
Correct.
and I know I'm overgeneralizing and it's not all people and not all cancers and all the things, but like with men, the burden is on the doctor. You better bring it up. It better be on the consent form. You better talk about it. Even if the guy, I got guys, they haven't had sex in 10 years. I still have to tell them risk of erectile dysfunction, risk of ejaculatory dysfunction, risk of infertility, blah, 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 blah.
Hmm.
Like, and they're like, yeah, whatever. I don't care. And it's like, but that's still a body part
Hmm.
involved in sex. We have to talk about it. And to
Right.
me, and I think especially in the breast cancer population, the amount of women getting double mastectomies because they just, and I don't want to speak for anybody, but it's like we have data that a lumpectomy and radiation's no better as far as survival than a double mastectomy, and women are cutting off these incredibly sexual pleasing organs. And it's like we're kind of in a rush. Maybe. And some cancers you have to be in a rush, but some cancers you can be like, let's see about what's important in life.
And that whole process of seeing what's important in life for patients comes in different ways too. So for some people, that cutting off the breast is because I can't live with the anxiety of, do I still possibly have to deal with cancer in my life? And by cutting off the breast, it's almost, I mean, in some ways, I think women think, okay, I'm just going to sacrifice it all. I'm just going to give it all up, and I won't have that anymore. But I also won't have the anxiety around. I wonder if there isn't some of that too.
Yeah, and as you're talking, I'm like, thank God for us talking about this in this podcast, because number one, this is super difficult for everybody and probably difficult for people to hear. But it's like, even people hearing it in a, you're in your car, you're contemplating, hey, if this was me, what would I do? Blah blah. Like the fact
Right.
that we're talking about it in society, then it's not such a, because you're right. Like we got to cure cancer, right? You need to cut off my head to cure cancer. Cut off my head to cure this cancer. But then when the dust settles, and we're really good at curing cancer, right? So the dust is going to settle, and you're like, oh, my sex life, my intimacy, my pleasure, my blah blah blah, and it's like to kind of just normalize the conversation socially, so that we're not, because I'm like, we can deal with anxiety. There are other ways of dealing with anxiety besides cutting off our breasts. Like, let's talk about that, because I think we do explain away the mastectomy of like, yeah, but then now they won't have anxiety. It's like, is double mastectomy the only way to treat anxiety these days? I
Yeah,
wasn't aware
that's
of
a
that.
really good point. I think until we as a society honor, respect uh, female sexual health and preserving it as we do for males, it, I think until we get there, there's always going to be a little bit more of what you see that way.
Mm-hmm.
That
When did
because
you?
you've never heard of it, have you? That, oh well, to preserve your sexual health, I think maybe this cervical cancer will handle it this way. It's just, preserving sexual health with females is it's just not a discussion.
It's so. I mean, I'm in such the male cancer world. Like that's my only
Hmm.
lens is the male.
Hmm.
Women have bladder cancer, women have kidney cancer, but as far as like sexual side effects of like the surgery or the radiation or the medications, I'm in such a male world that I look at your world and I look at your website and I look at all this stuff and I'm like, it's insane to me that we have to point out to people that we're not addressing women's sexual health, because my only cancer world is like, it's so ingrained in it. And then
Sure.
to me, I'm like, that's just such a gender bias that I'm like, why do they
You
need
know,
websites to remind people that this is important? Because it's not obvious to people.
and it's not even, I mean, even though we do better for men or male organ owners, we don't do great. We as a
True. Truth.
society don't respect sexual health for the quality of life issue that it is.
Yeah.
And we call it a survivorship issue because it's in survivorship that maybe when we're going back to our lives and we want our life back, that's when we that's when we are dealing with it, maybe more so than any other time. So it's obvious why it's called a survivorship issue, but this issue has to be addressed at the time of diagnosis so that expectations can be set, so that I know what to watch in terms of changes, so that I can get some help when I need it. I I couldn't. So what happened, just to go back to my
Mm-hmm.
own experience, I was told I wouldn't have sexual health concerns because I was young. They said 49, that I was young, healthy, and sexually active. Nobody asked me if I was sexually active, but I was married.
Okay.
So, and that I wasn't having internal radiation, right?
Okay.
That all of my radiation would be external. So I didn't expect to have any concerns. So when I did, so we were told 6 months, 6 weeks after the last is, I was treated in March, and the end of it was in March of 2008. And in May, I was told that we could resume sexual activity, to go slow and use oil. And it was, penetrative sex was impossible. I mean, not just uncomfortable, but impossible, to the point that I would have passed out. It was so painful, so immediately painful, that of course everybody's, he stopped, I stopped. It was concerning as to, oh my God, what happened? And when I went back in early June to say, you know, penetrative sex isn't working, I was speaking to a resident, and his first response was, it sounds like you're dealing with it really well. And I said, you mean because I can articulate what's happening? because I'm not dealing with it well, which is why I'm talking to you. And he said, well, I will get the physician, I'll get the medical oncologist, but anal cancer is rare. So we haven't had that many cases. So the physician said, it is rare. We haven't studied anal cancer as much. And I said, really? Do you think it's the treatment? Do you think it's the cancer? Because I'm not trying to have anal sex. And he said, I can tell you, it's not us. It's not medical oncology. It would definitely be radiation that caused the damage. So we need a referral. So we got in a referral there. And we continued to try. And radiation examined me and said, wow, we've never seen this before. We've never heard of this before. Have you asked? Have I done something? Is there something about what happened during treatment that went wrong?
Right. Is this my fault?
Is there fault somewhere?
Right. Or is it the fact that the anus is incredibly close to the vulva and there's collateral damage?
So what they said is, we'll get you a referral to a gynecologist.
Okay.
And a vulvar disease clinic. And there, then, I was examined again and given, I needed a procedure to take the scarring and the web scarring out, and then told, use it or lose it. But was then given dilator tools. So I'm into September now. I'm done with treatment in March, and I'm in September when I am getting dilator tools, estrogen cream, any sort of moisturizer. So 5 months, 6 months later, before I'm starting to be treated and then get a referral to a pelvic floor therapist. So instead of all of that happening immediately after my treatment was done, because I was cured. I mean, we were elated. I'm cancer free. All is good. Nothing's wrong here. And then you are this cancer patient where, you bargained with God on more than one thing to save your life here, or, that whole part of your brain that, if I make it through this, if I'm going to do better, I'm going to contribute, I'm going to give back, I'm going to be part of, I'm going to live a more purposeful life. You do all of that. And then when you're there, you're just so alone in all of this that you're really looking for the guidance that if you're not given, you're just alone. So 6 months later, you're dealing with what should have been dealt with immediately after, if there was a process in place, if anybody had addressed this topic, normalized it at all, to bring the issue forward, that knew where to refer, knew how to treat. I ended up with irreparable damage. So years later, I was told by the menopause and sexual health clinic, because I chased every treatment you could chase. I was told that I waited too long. The same facility said I waited too long. I didn't wait.
Yeah, it's like, I don't know if this is just what's crossing my mind, is like the medical field is so afraid of being held responsible or being sued, or like that we invalidate you, we make it your fault, we pass the ownership, like, and it's like, this is a suffering person who needs help healing. That's what we should be thinking about, not like, well, it's nobody's fault except for maybe it's your fault. And like, it's this very like dismissive fear of getting in trouble for causing something, when at the very beginning you could say radiation affects blood flow. It's very close to the vulva. Chemotherapy affects hormones. That's going to kick your menopause in. Like, none of this is a leap medically.
None of it. It's really quite surprising that if we looked at humans as, holistically, if we looked at them as beings, as opposed to with cancer. And it's really such a perfect storm, really. Sexual health wasn't on my mind either. It wasn't on my physician's mind. It's nobody's talking about it because nobody even needs to talk about it at the time of the diagnosis. So it's so easy to turn a blind eye to it. Everybody. However, this is my first rodeo. I haven't gone through this before. I don't know what to expect, and I do need this. So that's the part that I think is wrong and absolutely needs to change. You should have a process in place. I'm a whole person. That was 91% survivable, that cancer I had. I'm going to survive this. I'm going to go back to my life. You need to care about more than just the tumor in the
Yep.
moment because I'm going to live to be a ripe old age.
Yep. Yeah, totally. My first I don't know if my first aha, but like a strong aha. I was giving a talk at my hospital. This is years ago. I think I had started talking about female sexuality, but like it was early, like before the podcast and stuff. And a nurse from the oncology department came up to me after the talk and she's like, "Do you understand the rate of divorce after breast cancer?" And I was like, "I've never heard that there was higher divorce after breast cancer." And she's like, "Yeah, well, it's multiple things. Number one, you become somebody who's taken care of by somebody who doesn't usually care for people who are sick. So the relationship dynamic is affected just because of the status of what's going on." And she's like, "And then the sexual health needs of these women who've had surgery, who've had radiation, who've had hormone blockade, who have not been given vaginal estrogen. It's just like the perfect storm of, and now they're possibly financially devastated by a divorce." And that really opened my eyes to like, oh, right. This is a big problem.
I had friends that said to me, kind of on the side, like, Erin, did you not know? I mean, couldn't what? You don't know how to give and receive pleasure any other way but penetrative sex? How did you guys let this happen? And I thought, from the outside, that's a fair question. In the moment, when you're chasing treatment, your connection to your partner our connection pretty much was intercourse. It was a strong connection. When that didn't work, we just chased how to treat it, what to do. It changed the dynamic between us. We didn't think, really, this has to do with giving and receiving pleasure. Let's talk. Maybe we could do other things to give and receive pleasure. We were too caught up in also raising 4 kids and going to activities and living your life, but we were too caught up in fixing what we saw as so important and broken that we didn't look at it holistically, which is another thing that we need to help patients with. Set the expectation. There's a
Yeah.
good chance counseling might help you.
Oh,
It
yeah.
we needed it
Yeah.
so badly and didn't realize how badly until things had eroded to the point that we didn't have the energy for it. But we needed it. It's
Mhm.
funny how it's so difficult to talk to people you sleep with.
Oh, yeah. Well, I mean, to me, it's the overarching theme of like adults would have less issues if we actually understood adult sex ed. It's like how to communicate. What's the whole point of all of this? How to not just put
Right.
things in holes, hard things in soft holes. Right. It's like how could do it. And like the other crazy thing is like I've had, and again, my lens is talking to male patients more than female, but multiple men who your identity as a man is wrapped up in your erection. Like it's not just hard things and soft holes, but it's like I am a man because
Absolutely.
I get hard, right? There is a huge
Absolutely.
identity in there. And multiple men have told me, they're like, "Listen, I wouldn't wish this on, and don't get me wrong, I wouldn't wish this on anybody. But after prostate cancer, after whatever treatment, I now have better sex with my partner than I ever did have when I thought things were functioning how they were supposed to function." But that didn't come easily because you have to actually like learn what society never told you and learn how to
Right.
communicate and learn how to be intimate and like you have to, it's like you went through a college you never thought you would have to go through, right? And they're like, I don't wish that college on anybody, but like, oh my God, my sex life is so great now. And so it's like, it's this, I see the people who've gone through that and it's not easy. But several have told me this is better. But I wouldn't wish that on anybody. But it's like, what if we gave that information to everybody, cancer or not, on this end of things?
One of the things that we recommend at After Cancer a lot when we're talking to people who are starting survivorship programs or sexual health programs is to consider that whole prehabilitation. Consider that, oh, we used to do patient-centered care with Lamaze and where you have a group of like-minded people. So these are people that are going into breast cancer surgery or people that are actually, it started with Minnesota Urology is where I heard about it.
Oh, good job,
Where
Minnesota.
Yeah, yeah. And it had to do with prostate cancer. So too few people able to educate so many patients. They decided to do a prehabilitation class with prostate cancer patients and their spouse or partners could come to this. And at the class was the surgeon and a pelvic floor therapist to get them ready for the types of exercises that they could be doing now and could have a baseline to know how they're doing and then what to expect week 1 and week 2 and week 3 to keep your patient actually compliant and understanding what to expect so the anxiety isn't so great. But also then have a couples counselor or just bringing forward some of the psychosocial concerns that navigating intimacy isn't easy and there are just some real obvious things that have to, and communication is one of them. And possibly people aren't at a place where they are communicating well, that the baseline at the time you have cancer may not be that you communicate well about sex now. So it's not going to get better.
Yeah, or the communication was sex.
Or the communication was sex. Yeah. And that's real common too.
Mm.
So all of these things could be in a prehabilitation class. So we really recommend if you have the resources you could have somebody there with nutrition, you could have mindfulness, you could have yoga, you could have people there to give strategies of how we can do better to help beings through this.
Yeah. Yeah, well, I've been thinking about this a lot lately, and I don't know if there's something to do on a national level or what, but I was, the amount of resources that go into people keeping their hair with cancer treatment.
Yeah.
And we've got the cooling caps and we've got the things. I don't know all the stuff, but it's like, and it's very public. Like people will post that on Instagram of like, I'm doing the stuff to try to keep the hair, and it might not work, but I'm doing the things. And at one point I was like, if we took that much energy into keeping hair as we did for can we give everybody pre-treatment with vaginal estrogen? Like it's such low hanging, like why isn't vaginal pre-treatment a thing? Again, not for every not for your shoulder melanoma, but like for pelvic health, for radiation, for breast cancer, for everything where it's safe. Why isn't pre-treatment a thing? We care about hair.
It's a really good point. And it, like you said earlier, it's not a leap. We know what the treatment causes. We know what the side effects are. We know how that's going to impact us and the sexual response cycle. That it isn't just whether or not you can have penetrative sex, or is there erectile dysfunction or not, or pain with penetration. That it has to do with desire too, and so much impacts desire, including fatigue.
Yeah, I was going to say exhaustion. I mean, I think just the healthcare team being upfront with people, and it's this fear of like, well, I don't want to scare you from cancer treatment. It's like she's going to do cancer treatment if it means cutting off her arm. She's going to do it. But the fact that she actually knows that and now she knows that this might be a bumpy road. She might get some of these things. She might not get some of these things, but it is a bumpy road. It just gives you a little bit of a seatbelt for the ride instead of being like, am I the only one? Did I mess this up? Everybody's saying this isn't a thing.
Yeah. That is where our training that we do at After Cancer, that actually is what it is all about, is giving a patient message, a 30-second message, and it's just to normalize that conversation for patients so that expectations can be set, referrals can be made timely. So it's um, patients need to be guided. And I remember as a patient, I cared a lot about what the oncologist and my team said I should and shouldn't do. You know, it's when my Bible, I would do what they said. And them not talking about sexual health or anything that related to that suggested to me that it shouldn't be important to me. Maybe because I wasn't going to have any
Ah,
issues, but it's also not important. So having a message, a patient message, I think is so important just to normalize that for patients and to give them just some kind of guidance here on issues are common. They may be short or long lasting. They may be mild or severe. Issues are common though. Sexual health side effects, and they could name them. They're common, but we have resources to help those things. You need to know about it now because issues that are addressed sooner versus later are better resolved. The chances are better we're going to resolve them. I waited 6 months. It was irreparable. Penetrative sex would no longer be a thing. And that's just one radiation treatment,
right.
having 25 bouts of radiation treatment
Yeah.
before I was menopausal.
What, take me between your journey to you now being involved with these organizations and the advocacy. How did that happen?
So after that purposeful life that I told you that, you plan for when you're bargaining to live, I took life coach training. I became a life coach and worked with patients, not just about sexual health, because I didn't know sexual health was going to be such a focus. This was a long journey for me on my sexual health, the challenges I was having. I didn't realize it was going to end the way it did. Uh, However, I did think the emotional challenges after being a cancer patient, the emotional, spiritual challenges around that, I thought were worth helping patients through. And so I became a life coach and I did a lot of coaching with patients just on that topic. But I was so darn curious about their sexual health because I was going through it that I would ask everybody, so how's your relationship changed? How has anything changed about how you feel as a sexual? And because almost unanimous people had concerns, whether not all of them were penetrative sex related. Some of them were just, he is not attracted to me anymore. And I know he's not. We have nothing between us because he doesn't want to touch me. Never was that confirmed, but it was the feeling which changed the dynamic,
Mm.
which changed the relationship, which made it
The power of assumptions too,
right,
right? Like the
right,
assumptions can ruin your
right.
life and be wrong at the same time.
And it was not a topic that was easily talked about between people, so it never got discussed. So that really just kind of inspired me to go back to the oncology community and say, you've got this so wrong. You've got to do better for your patients. So I collaborated
Were
with
they
the,
open to you? I mean,
well, I
you
went
had
to it.
some clout because of your journey, I would think, than like some
Well, I didn't have
stranger.
any clout because I wasn't a clinician. So I went to a urologist and a gynecologist. So not even an oncologist. The three of us, a patient, a urologist, and a gynecologist, wrote a presentation for oncology nursing this is what your patients need to know. And that was the presentation. And we gave it to oncology nursing around the state of Iowa. And I was approached by the Iowa Cancer Consortium why didn't I write a grant? Why didn't I apply for funding to actually develop the materials I was suggesting people needed? And so I did, we did, and we did for 5 years do just that. So that's where the work began in 2016 of creating materials. So educational materials and workshops. So how for the care team members, so nurses and navigators and social workers and radiation and physical therapists, and then APPs also, but on how to address sexual health and cancer care. So we understood first all the barriers to care, got focus groups of patients and focus groups of providers to understand, why aren't we talking about this today? What's that communication gap all about? And we learned all of those things, which there are many good reasons on both sides as to why it doesn't get discussed. And then we just developed education that just addressed every single one of those barriers. So that's what we do today. So we became a nonprofit organization in 2022. So it's our mission really is that all patients impacted by cancer be screened for sexual health side effects as part of their care, a standard of care.
Standard of care. Love that. And I think, I mean, the other thing I love that it's so multidisciplinary, because I think doctors are like, dude, you know how much I have to get done in this amount of time, and to take the pressure off of them of like, the doctor doesn't have to do all of this. This
No, they
just
don't have to
has
do
to be
any of it,
within.
actually.
They're perfect. Not that they don't care, but it's like the burden can't always be at the top of the stream, right? It has to be in the house. And so,
And honestly, even from a patient perspective, I didn't want my oncologist talking about sexual health. I had 7 minutes with him.
yeah,
I wanted to talk about the cancer. I did want to talk about what his knowledge, just that. But the care team, I was connecting with the care team at a deeper level than I was my oncologist.
yeah.
So it was the perfect place, really. The nurses
Totally.
and the navigators and the social workers. And of course, those advanced practice providers, they definitely belong in our targeted audience of training for addressing sexual health. We just go a little deeper with them to actually evaluate and screen for it, treat what they can, refer what you have to, but treat what you can in the clinic at the time.
Yeah, I love that. And I think that's that's something that Ishwish often says is like, know who your referral team is, because you don't have to have all the answers. You're not going to know everything. And so know, who can you ask? Who can you call? Who can you refer to?
Right.
Let's share resources both for prescribers and the APPs, and then for the lay person who might be on the journey of cancer. Can you share where you'd like people to go?
We're really provider facing, just in terms of our education. To date, we have been provider facing. So aftercancer.co is the website, and our resources for providers and care teams are workshops and courses. So those courses we're making them all online. So we have a sexual health specialist course for APPs and navigators. And this year, in the next 60 days, we'll have the 30-second message course for the nurses and the navigators and the social. So still some of the same crossover. And it is learning that 30-second message. It's for those people that don't have time but have 30 seconds.
I love that. That is brilliant.
They need to know how to lead into that and exit from it. So it's learning exit strategies based on patient responses. And then where do you refer the patient to? You refer the patient to someone in your clinic first, probably. There's an APP that wants to see your patient first. And then, so there's a course for the APP, and then there is a referral roadmap that we help them create. And that roadmap is, who are your common referral sources, not only from a provider perspective, but maybe even on the patient side from a support group perspective, or some of the mindfulness, some of the integrated care.
I love that. And then for
the patients, and sorry, I didn't mean to interrupt you.
No.
For the patients, I have been asked if we would create a patient. So I've been asked from providers, actually. And so we are in the midst of applying for grant funding right now to create a patient force that will be, kind of like all psychosocial concerns with learning pathways specific to certain patient populations or types of cancer, like gynecologic cancer or prostate cancer or breast cancer, head and neck cancer, and then also some of those pathways related to maybe adolescent and young adult, or the geriatric, or the metastatic.
Yeah. Oh, I love it.
So we're doing that, and then creating a social work course. So that's where we are on the journey, and would love to have more involvement. So I'm thrilled to be here, and I appreciate you highlighting it.
Oh, well, thank you so much for coming on. Any final words you want, either doctors or patients or their lovers? Any final thoughts you want anybody to know?
This is just not so, it's just not so mystical. It really is just at the core what all of us need to be emotionally healthy. It's that emotional intimacy, and it's also derived a lot of times through physical intimacy. But we need to not forget that even that emotional intimacy, gotten to that in a lot of different ways, is really where we all find our peace and joy. And the physical intimacy, the sexual health, is just a real obvious pathway to it.
Oh, I love it. Thank you so much for sharing your story, sharing what you've created. And again, the fact that we can have these conversations for people to listen to when they're not in the doctor's office so they can kind of think, and also for
Yes,
providers to be like, listen, you don't need to become sexual medicine experts. We just have
right.
to, eat the elephant one
That's
bite
right.
at a time of like, know
Right.
what the plan is. I love the 30-second idea. Like, what clinician can't get on board with a 30-second spiel?
That's right.
That's brilliant. So thank you so much for coming on today.
Thank you so much.
Absolutely.